Peritoneal dialysis catheter care plan. Swan Neck catheter nurses' roles and patient education during pre and post PD catheter insertion. By Gazelle Tangelin.
What is peritoneal dialysis catheter? It is the only type of access for peritoneal dialysis that is surgically placed in your lower abdomen. It is a small piece of tubing that is left outside of the body that can be covered when not in use. The PD catheter have three segments. The external segment, which connects via an adapter to the solution transfer set. The intramural segment has Dacron cuffs spaced about 8 cm apart. By creating an inflammatory response, fibrous tissue fixes the catheter into position, thereby minimizing leakage of dialysate and preventing bacteria from entering the catheter tunnel and intraperitoneal segment. The intraperitoneal segment, which has many small holes up the side for the in and outflow of the solution. There are different types of PD catheters. Each type varies in shapes, lengths, and sizes. It also varies in the design, which includes the number of cuffs 1 versus 2, the design of the intramural segment permanently bent versus straight, and the intraperitoneal portion straight versus curled.
Today, I will specifically discuss the Swan Neck catheter. The Swan Neck catheter, also called the Preesternal catheter, is a modification of a lower abdominal catheter allowing for an exit site on the upper chest. It has 2 downward pointing segments. Migration of this type of catheter is rare, thereby serving to aid outflow. Its downward points also thought to prevent infections at the exit site, thus preventing the accumulation of sweat and pus.
Catheter material. The Swan Neck catheter is made of extremely kink-resistant silicone material that provides comfort to the patient. The typical shapes of catheter tips include straight, pigtail curled, and swan neck form. The rationale for use for the Swan Neck catheter includes less movement with the chest wall location than with the abdominal location, therefore there is an increased healing and less risk of trauma to the site. It has a permanent bend associated with an intercuff segment. Patients that are obese with multiple abdominal folds can use this configuration. It is useful in patients that are incontinent or have ostomies. It is used for patients that like to bathe, as it is usually kept out of the bathwater. The advantages of this catheter are the following. It can be used by patients that have dexterity problems. It can be cut to size for the patient that allows a preesternal or upper abdominal exit site. It is ideal for patients with an active lifestyle. It has reduced the risk of exit site infection. It is a good catheter choice in obese patients and patients with ostomies and incontinence that have a problem in handling a catheter at the belt line. While its disadvantages includes insertion technique is more challenging, as it must be inserted surgically and cannot be inserted laparoscopically. It has a slower flow of the dialysis solution due to the increased length of tubing. It has safety issues over disconnection in the tunnel, particularly in fast-growing children. It has a higher risk of catheter colonization by bacteria during peritonitis incident with subsequent recurrent peritonitis. During the pre-insertion preparation of the patient, a full preoperative assessment must be done to identify existing or potential hernias. If present, these can be repaired during the insertion. It is essential to identify the patient's lifestyle, work, and hobbies when placing the catheter. Assess the catheter exit site before the catheter is inserted. The preferred site should first be discussed with the patient to help promote participation in and an understanding of the therapy. When determining the exit site of the patient's catheter, the site should be determined while the patient is in a relaxed sitting or standing position. It should be either above or below the belt line, whichever the patient prefers. Skin folds and abdominal scars should be avoided. The catheter exit site should be located where the patient can effectively carry out exit site care. Once the exit site has been determined, it should be marked clearly with a permanent skin marker. During the preoperative care of the patient should bathe or have a shower on the morning of the operation. The patient can use chlorhexidine to shower as well. Abdominal hair should be clipped. The patient should have bowel preparation, since a major cause of catheter failure, particularly at the start of PD, is constipation. Therefore, it is recommended that a powerful aperient such as Picolax is given the day before catheter insertion. Also, distended bowels can interfere with the placement of the catheter. The patient should empty his/her bladder before the insertion procedure takes place. Do Staphylococcus aureus screening. According to a study, patients who have nasal carriage of S. aureus have an increased risk of exit site infection and peritonitis, and that the use of mupirocin cream or ointment at the exit site is recommended to reduce the incidence of infection. Have prophylactic antibiotics, as there is evidence that this prevents catheter infections and peritonitis. Identify the psychological preparation of the patient, as this is of absolute importance for someone new to PD. The goals of postoperative catheter care to the patient are also as follows. Minimize any bacterial colonization of the exit and tunnel during the early healing period. Prevent trauma to the exit site and traction on the cuffs by immobilization of the catheter. Minimize intra-abdominal pressure to prevent leakage. During the post-operative care, it is important to keep the exit site undisturbed for 7-10 days following insertion of the catheter. If during the first 10 days the dressing becomes soiled, it should be redressed by a nurse. If it merely becomes dislodged, it should simply be replaced with a fresh sterile dressing. During this period, the catheter tubing must be immobilized by securely taping it to the patient's abdomen. Local unit policies will be in place and should also be followed. The catheter should also be immobilized at all times to prevent trauma. Flushing with 500-1500 ml of PD fluid is also necessary to check patency. This should be directly followed after the insertion of the catheter of PD fluid. Ideally, PD should not be started until healing of the exit site and tissue ingrowth into the catheter's Dacron cuffs have taken place, usually after 10 days. If dialysis is necessary before this time, automated PD would be the preferred method to minimize the risk of leakage of PD fluid by allowing the patient to be treated using small fill volumes of fluid in a supine position. Also, instruct the patient to change the dressing weekly for the first 2 to 3 weeks. Avoid submerging the site in water during this time to prevent any waterborne organism. Use aseptic technique during dressing change. Use non-occlusive dressings so it will drain and dry rather than the pool at the exit site. Also avoid any activities that increase intra-abdominal pressure such as coughing, constipation and straining with the stool, bending over, and squatting. The long-term care of the exit site goal should fit the lifestyle of the patient to encourage full participation in the treatment and therefore reduce the risk of complications. As with any wound, care is aimed at keeping the site clear of exudate or debris that could encourage bacterial growth. Protocols include washing hands before doing site care, cleansing site with the following points to consider. Avoiding harsh solutions as they have the potential to cause skin damage, which may predispose to bacterial colonization. Different agents may be preferred in different circumstances, such as antiseptic solution in an immunosuppressed patient. Ensuring exit site is carefully dried to avoid skin maturation, which could predispose the site to bacterial colonization. It is also important to do cleansing in a clockwise motion, starting closest to the catheter and working outwards. Do not remove scabbed areas, and keep the catheter exit site covered. Do catheter immobilization. From the moment the catheter is inserted, it should always be securely anchored to the patient's skin using tape or a commercially available immobilization device or tube holder. To avoid torque movements at the exit site and reduce the risk of exit site infection, swimming and bathing can also be discussed with patients once the exit site is fully healed and ideally free from infection, with the following recommendations. A waterproof or occlusive dressing should be applied, and the exit site should be cleaned, and a new dressing applied immediately after immersion in water using the normal technique. Also, do not immerse the exit site in water without a waterproof dressing, particularly hot tubs, jacuzzis, and so forth. Diving should be avoided as this may put tension on the catheter at the exit site. Assess for signs and symptoms of infections such as pain/tenderness, redness, drainage, crusting. There are many psychosocial challenges involved as patients adapt to PD. As nurses, it is important to discuss in detail these concerns to prevent any complications. Some concerns include the body image disturbance. There is a psychological impact on how patients feel with a potential foreign body in terms of a PD catheter inserted into their abdomen. It may be a constant reminder of living with their chronic illness and has been regarded as the patient's lifeline and therefore must be monitored carefully. If you are struggling with how you feel about your body, consider that. Your body is important, but it does not define you as a person. You are likely more critical of your body than others will be. Your feeling towards your body can become more positive over time. Any changes to the body may be upsetting at first. It often takes time to adjust physically, emotionally, mentally, and spiritually. More positive feelings may come over time, but there are also ways to actively create a more positive perspective of your body. It is normal to have many different emotions and thoughts while experiencing health changes. Therefore, it is important to speak to a social worker or counselor, speak to other patients dealing with similar issues, peer support, speak with family, friends, and caregivers who you feel will are supportive, and speak with a team member to get additional support.